The biggest unmet need clearly is drugs that are acting on the central nervous system itself. I think we became very efficient in treating the immune system and preventing relapses, preventing lesion formation. I think that's a really achieved goal, so to say. But I think the continuous process in the CNS, both inflammation and degeneration, is only partly dependent on this de novo infiltration. And that's a process we are only starting to understand, which is probably really relevant for disability, for atrophy, so for the hard outcomes, so to say, in patients. And these probably can only be influenced by identifying and targeting crucial steps within the central nervous system, probably involving microglia, astrocytes, so new players of CNS resident cells, where there is basically no evidence that any of the established MS drugs are affecting these cells at all.
It's hard for me to identify just one. I mean, I think one of my interests in comorbidity is that it gives us a more patient-centered approach. So we're not just focused on fixing the MS, but we're saying we have a person with multiple sclerosis who always also carries with them an entire life history and other conditions. And so we need to find a way to really be able to tailor our care both to that individual's goals and needs, as well as to the specific aspects of that person, so that we can really come up with a regimen unique to that person that will really give us the best possible chances of improving their quality of life.
I think the biggest unmet need is overcoming something called therapeutic inertia. And so in our field, therapeutic inertia is ripe. And what I mean by that is you identify that someone's not doing well and you don't change what you're doing to take care of them. This is a concept that was originally born in the hypertensive literature. You got high blood pressure, you started medicine, at follow-up you still have high blood pressure, nothing changes. Here the stakes are much higher. And I think that for multitudes of reasons, patients, clinicians, even third-party payers are complicit in allowing a patient to languish. It's even worse in that the effects that we apply, drugs that we apply today, we're looking for downstream benefits 15 years from now. And so if you're not attentive, you don't see change too quickly. I think that the biggest unmet need is addressing the critical importance of timely diagnosis and timely escalation of therapy when appropriate. We're missing that piece. And it's my hope that as we move forward as a group of treaters that we overcome that.
All the therapies that are presently available are really anti-inflammatories of one form or another. They all modulate, suppress, alter, change the immune system in one way, shape, or form. But there's a whole neurodegenerative component that's out there, and focusing on neuroprotection, focusing on remyelination, focusing on repairing and replacing damaged nerves in the brain and the spine and optic nerve. To me, that's the next step. We have to get to there because there's an incredibly large unmet need for a lot of people with disability who either never got access to the medications we've been talking about, or they, for whatever reason, didn't do well with them. So to me, the biggest unmet need is progressive MS and altering our view, trying to move not away from, but in addition to immunotherapies, to the addition of those things that will protect and or salvage the nervous system.
So hand in hand with having therapies for progressive MS, what we need is reliable biomarkers that any neurologist in his practice, her practice can use in order to monitor disease progression, response to therapy. And we're actually going to need that when we come up with trials to test these new candidate drugs, because as you know, it's very difficult to run a trial on progressive MS. So the more the data we can get from those trials, right, and the more sensitive the signal we can get from those trials, the better will be. So unmet clinical needs besides therapies for MS, for progressive MS, I would say biomarkers, reliable biomarkers.